Okay, so we are going to talk about the different electrical conduction systems of the heart, premature ventricular contractions, idioventricular rhythms, and accelerated idioventricular rhythms.
We've lost
Talk about VTAC, we're not going to talk about VFib, ventricular asystole, pulseless electrical activity, and the clinical significance of ventricular rhythms. So the rhythms are classified according to the heart structure in which they begin or their site of origin, right? So the SA node or the AB junctional tissues fail to generate an impulse, right? So this isn't occurring in the SA or the AB node, right? If this failure develops, the ventricles will assume the role of pacing the heart. So what's in the ventricles that controls the pacing? Purkinje fibers, yes. Rhythms that are initiated in the area of the ventricles are called ventricular rhythms. They're the least efficient to the heart's pacemaker. You should recall that the patient's assessment is the most important when it comes to clinical or indicator of clinical significance. So if they're in VTAC and they're stable, it's going to be a whole lot different than VTAC and unconscious, right? You're an ass. I didn't hear it.
I didn't hear it either.
She just opened a
Show it.
Don't swear, we're filming.
Oh, it's the same one.
Off your iPads.
Oh, you gotta turn it vertical.
So components of the electrical conduction system of the heart. Electrical impulses originate in the SA node, travel through the atria via the internodal pathways into the AB node. Brief pause, bundle of His, right and left bundle branches Purkinje fibers into the ventricular musculature. You guys all know this, we've covered this as we've gone, right?
This actually is repeated every single chapter, so.
Okay, so you guys know this, okay? You guys know this? So impulses that are ventricular in origin begin in the lower ventricular musculature. Impulses may travel in retrograde direction to depolarize the atria. Either way, the normal conduction pathway is bypassed. So when it comes to ventricular rhythms, your QRS is going to be wide. This is how you identify ventricular rhythms, right? Wide QRS. You're going to have an absence of P waves because they're hidden or buried in the QRS complex. Do you guys understand that? Okay. So remember the QRS complexes of supraventricular rhythms are commonly less than 0.12. So if they're ventricular, what are they going to be?
More than 1.
More than 0.12. Individual complexes rather than an actual complex. These are PVCs. So you guys understand what PACs are?
Yeah.
Okay, so PVCs, way more common. This is what you're going to see quite a bit. So this is a single ectopic out-of-place complex that occurs earlier than the next expected complex. Okay? Arises from an irritable site in the ventricles, and the significance of PVCs is based entirely upon the patient's clinical condition. So there are people who will every day have PVCs and they will never know because it doesn't affect them any which way. Yeah. So the underlying cadence of SA node is not interrupted by a PVC, nor is SA node depolarized. So it's usually followed by a compensatory pause. Presence of a compensatory pause coupled with wide, bizarre, and premature QRS complexes are highly suggestive indicators of PVCs. So, do you guys see the PVCs in this rhythm?
Yes.
Does everybody see them? Raise your hand if you don't. Okay. So, this right here is going to be a PVC. This right here is going to be a PVC.
Okay.
Okay? Do you understand why? Okay, it's wide. You can see a little bit how the P wave is starting to go into the complex. Okay. So these just happen to be uniform PVCs. You can have ones that aren't uniform. We'll get to that.
So the other ones are sinus or SA originated. They look good, right?
Yeah.
And then there's just these random ventricular ones.
Yeah. And you can see that they're the compensatory pause, right?
Mhm.
So there should be a nice SA caused complex. Instead, you're getting a premature happening before. Ventricular, because it's wide, complex. Yes, Nick?
So then would this be a normal sinus rhythm with underlying PVCs?
This would be a sinus rhythm with
Sinus rhythm.
PVCs, yeah.
PVCs.
Yeah. This is, so it depends if they're perfusing or non-perfusing. If they're perfusing, the rate's gonna be higher. If they're non-perfusing, the rate's gonna be lower, right? Justin?
For the sake of like, when you count them in 6 seconds to find the rate, do you count PVCs as like, as
Yes.
one? Okay.
That's what I say. In real life, they might be bradycardic because these might be non-perfusing, right? So what does non-perfusing mean?
No, not a clue.
It means you don't get a pulse with them, right? They're not perfusing to the point where you can actually get mechanical pulses.
Would anxiety cause this?
Not typically. You'd have to be awfully hypoxic for that
So-
to start happening.
Is another way to think about that then is it's just strictly electrical and it doesn't generate the beat? Is that what you mean by non-pulse?
Non-perfusing would be just electrical, non-mechanical.
Okay.
Yeah.
Can you explain the compensatory pause?
Yes, so you can see when this happens, the rate is gonna pause to compensate for this
And then reset.
and then reset,
Okay.
right? So if you map this out, these would be regular with these, and you can see where it is.
So an
Can I borrow a piece of paper? Anything?
it's an exact chunk that you could take out of there that destroys the rhythm.
Thank you. So you can see, like if we were to map these two and go here, you could go, okay, well this would be here.
No.
Otherwise it would be perfect.
Regular.
And this is why we're taking. That's very good.
Right?
That's the pause.
So the
That's the
PVC really
pause.
just screws up. speed.
Premature.
So it's the PV, I don't even know what I'm saying really. So it's regular then, right?
Yeah, it's
Okay,
regular.
So overall regular except for the PVC, just kind
Yes.
of off throwing it there.
Yes. Yes?
Yeah.
Yeah, that makes sense.
That actually,
That makes, yeah.
That makes a
Okay.
lot
Because we
of
Something
talked
is
about it
correct.
yesterday.
That,
but
that
I
was
didn't-
great actually, the way you did it in paper.
Okay,
That
yeah.
really made
And
sense.
if you want to do that, like every practitioner worth their salt will do that on a call. Whatever method they have, whether it's the folding in half method, whether it's draw down on the paper, you will see them doing that on the ECGs. Like it's not even a made up, we don't look at them and go, oh, you know what, that's this and this and this. It's like, I'm gonna map this out and figure out exactly what it is, or I'm gonna look like a,
Idiot, read chart.
I don't know if we're still taping.
We're taking.
Yeah.
This is only going to the people not here though, right?
That's right.
No, good shit.
and YouTube.
YouTube. You know,
YouTube.
our private,
No,
our private files on
Are you
YouTube.
like filming or recording? Like,
Same
Videoing.
thing.
oh, there's video, okay.
Because that there was worth turning on the camera, right?
Yeah.
Worth trying to practice.
So PVCs may fall between two sinus beats without interfering with the rhythm, referred to as an interpolated beat. So PVCs appear in many different patterns and shapes. The morphology or shape of the PVC is based on the site of origin of the ectopic focus. So you can see, oh, it's not up there anymore clearly, but those were uniform in shape. You'll notice that when you start seeing more PVCs, you can see non-uniform PVCs. And that's because they have, there's more than one place in the Purkinje fibers that's shooting off these PVCs, right? So depending on where it is in the heart, that's depending on what they're gonna look like.
But they'll still hold their regularity of beat. Their shape could be different.
Yes, they
Yeah.
should maintain the regular beat.
Okay.
So ventricular bigeminy occurs when every other beat is a PVC. Okay? Does that make sense, or do you want me to draw it out?
It'll be the next,
Okay.
it'll be the next
It'll be the next slide?
Yeah.
Okay. Trigeminy occurs when every third beat. Quadreminy occurs every fourth beat. And couplets or repetitive PVCs are 2. Runs of VTAC are as soon as you get over, or 3 or more PVCs in a row. That's technically a run of ventricular tachycardia. Okay? Does that make sense? You guys can ask questions as we go, it's okay, I can,
We're thinking really
I have
hard.
no
you guys
questions
look
that
like you're thinking really hard.
Half of it's clicking and half of it isn't.
It's really good to follow along the books, they show them all as you're talking, so.
So this is the 5 questions that we're gonna ask for everything, right? So the rate is gonna depend on the underlying rhythm and the number of PVCs. The rhythm is gonna be occasionally irregular, but regular if interpolated PVCs. Is there a P wave? No P waves are associated with the PVCs, might be in the underlying rhythm. PRI is not present with PVCs, and the QRS is usually wide and bizarre, equal or greater to 0.12 seconds. Another example of some PVCs. Everybody see the PVCs?
That one and that one.
Yes. Does everyone understand why they're PVCs?
Why QRS, no P?
No P wave and?
Why QRS?
They're before where the next regular beat should be, right? They're prematurely occurring.
I don't get what it means by unifocal or multifocal.
Okay,
Is that
so
up
right
and
here,
down?
this is unifocal, or this is multifocal. Different PVCs occurring from different origins. They all look different, but they're all PVCs, nonetheless.
And the uni looked the same, right?
What's that?
The unifocal.
Unifocal all look the same. That would have been this one. Unifocal, multifocal. Yes? Okay. So these often indicate myocardial irritability. Multifocal PVCs are more serious than unifocal PVCs. Salvos or runs of BTAC, any indication of increased myocardial irritability dictates that the patient may be carefully evaluated and managed. So this is ventricular bigamy and couplet PVCs. So where are the PVCs in the strip? Justin?
It's the big ones, so like
The last one.
The last 2.
isn't the
All the big
every
ones.
second beat
Yeah.
one as well?
Oh, wow.
It's
pretty
by
wide,
Gemini
correct?
for the first, like.
Oh, I'm sorry, I was looking at it, I was just looking at these. I didn't even see these.
Yeah.
So yeah, this is by Gemini. It's occurring after every regular beat.
And then you get the couplet themes.
So you got PVC,
So, regular
PVC.
beat.
So those little tiny things
Yeah.
are regular.
Those little tiny
I guess
things are
so.
It's a regular
QRSs?
beat.
Yeah.
All that mess.
That's kind of a messed up one to use.
That's not fair.
So this is better. This is by Gemini. Is it multifocal or unifocal by Gemini?
Multifocal.
Multifocal. Why?
Because we're
The
different.
second one's weird.
The second one's weird, yeah.
The last one's really weird.
They're all the last two ones.
So what about this one? This is ventricular trigemini. So every third beat is a PVC. Unifocal or multifocal?
Multi.
Multifocal, yeah. Idioventricular rhythms, also termed ventricular escape rhythms, considered a last-ditch effort of the ventricles to try and prevent cardiac standstill. Means the SA node and the AV node have failed.
Oh no.
This is usually at a rate less than 40. It's an agonal rhythm. So agonal rhythm is when the idioventricular rhythm falls below 20 beats per minute. This is, if they're not actually in cardiac arrest, they're about 30 seconds from going into cardiac arrest. Frequently it may be seen as the last ordered semblance of a heart rhythm when either resuscitation is unsuccessful or after successful defibrillation.
So right after they get defibrillated, it'll go into that pattern,
It can, yeah.
and then it'll kind of
It'll
convert
either
itself out of there.
It'll either peter out and go back to an agonal, non-perfusing rhythm, or it can turn into a normal sinus, not typically. So causes include extensive myocardial damage secondary to acute myocardial infarction or failure of higher pacemakers. So when it says pacemakers, does it mean implanted pacemakers? No, it means the SA moving node, right? It's considered to be a lethal rhythm, and treatment must be immediate and aggressive. So, idioventricular rhythm, 5 questions we ask. So, the rate's going to be 20 to 40 or less. The rhythm is going to be atrial, not distinguishable.